today. I'm really excited to be talking about this topic with everybody here who was able to make it. So before starting the presentation, I did have some poll questions I just wanted to ask just to get to know my audience a little bit. There is a link to the poll in here, but I think it might be easier if you could just type out your answer in the chat instead, if that works. Does everyone here have access to the chat? If you can have it open, I will go ahead and share my my question here. You can either put the message in directly to me or into the chat. That works either way. Okay, excellent. I think most of the people have either messaged me or sent a message in the chat. I'm going to go ahead and just ask my next question. I was hoping you could tell me a little bit about your prior knowledge of FCS. Just going to give it a few more seconds. Okay, thank you so much for sharing your responses. And then just the last one, if you could tell me what you were hoping to get out of this presentation. And if it's something else that's not on this option list, please feel free to put it in the chat as well. Okay, excellent. Thank you so much, everyone, for taking part in the poll. Without further ado, we will get started with the presentation itself. Just going to take a second to share my slides here. I will say that we will have time at the end of the presentation to ask any questions. Jill, if you could just give me a thumbs up if you can see my screen, that would be great. Okay, excellent. Let's get started. So we have more time at the end of the presentation to have a discussion if we want it. So first of all, I just want to begin again by thanking and also declaring that I don't have any conflict of interest financially by presenting this slides today. I don't have any ties to any pharmaceutical companies and I'm also not receiving any financial compensation for doing this. And also want to clarify, although I am in medical school, I am not yet a licensed physician, and all your medical concerns should be discussed directly with the physician taking care of you. And I would not be able to provide any personal individual medical advice, but I can speak to my region now and talking a little bit about what FCS is, the genetics behind it, understanding what lipids mean and when they show up on the blood work, the clinical signs and symptoms, the investigations and diagnosis. And I understand some of you have already had some of the experience with it. And some of you might not still. So I'm really hoping that we can find some sort of balance here to learn from each other. And also we'll, in the later half, we'll talk about complications, some cautions about some medications out there and what research says about some of that, the management options that are presently there, the experimental and emerging therapies, as well as leaving some time to answer some questions and have a discussion. So as you know, FCS stands for familial chylomicronemia syndrome, but that is not the only name that is found in literature or when you look up FCS. So the reason for highlighting this is it's just to clarify, that some of these mean the same thing. And the more commonly ones that show up are lipoprotein lipase deficiency. It's another alternative synonym that will show up more commonly. Familial LPL deficiency, chylomicronemia syndrome, familial hyperchylomicronemia, as well as familial hypertriglyceridemia. The reason it's important to know those is if you're looking at research, if you're trying to find clinical trials, they might use some of these alternative names. And might not refer to it necessarily as FCS. There are other ones that are highlighted here too that you can find, but the other ones are not as common, but they are there for your reference. So I'm just going to start my presentation by basically looking at this. There's this really good YouTube resource, and it's in my list of resources at the end of the presentation that I will be sharing. I think it's a very good one if you want to explain FCS to somebody who doesn't know much, or you might want to explain it to either even a healthcare professional or patients or relatives that you want to explain more to. But it does a very good job of basically being concise and to the point. So I have derived some of my slides actually from that video. So I will go over that just to get the basic understanding out of it. So FCS stands for the familial part of it. Essentially comes from the fact that, as we know, that it can run in families because it is passed down through our DNA and genetics. And there are different parts of the world where the disease is more concentrated than others. Quebec, Canada being one of them, which is why you will see a lot of research actually comes out of Quebec as well, and Canada itself. With regards to FCS, because we do have slightly higher proportion of the population, even though it's such a rare genetic condition. So the chylomicronemia part, again, it's referring to the fats in our body that build up in the blood. And we'll be talking a little bit more about chylomicronemia in itself. And as some of you might be aware, FCS is not a single symptom. It's not a single increase in a number that matters. It's a group of symptoms that people can experience. that form this medical condition. Hence, that's what FCS is. And I do want to, say again, apologize a little bit if some of it might be already something that's clear to you. The reason I am talking a little bit more in depth is because we have a varying level of knowledge and background in this group today. So if you know more, if you know less, just bear with me until we get to the part that maybe you might be more interested in. So essentially, how FCS works in our understanding is that, so usually when we eat food, our food, whether it's protein, carbs, or fats, we use a lot of it to produce energy. Our different tissues in our body use it as a form of energy. But what happens to food that is broken down but not used are stored as triglycerides and chylomicrons, and those circulate basically in our bloodstream to be delivered to different tissue when our body does need them. So the unused energy is stored in our body as fats, as those chylomicrons that's basically circulate in our blood. So what happens with those fats when we do actually need them is that we have an enzyme in our body, and more specifically lipoprotein lipase, that's expressed in extrahepatic capillaries, basically in our blood vessels, that's responsible for releasing triglycerides from the chylomicrons and breaking them down into smaller components that a tissue would be able to use it for, such as monoglycerides and fatty acids. So this is an important point to clarify, because in the beginning, I've talked to patients even who are sometimes confused about why can't we just give like another lipase, like pancreatic lipase or other things that are suggested to patients. But there are many different kinds of lipases in our body. There's hepatic lipase, there's pancreatic lipase, there's lysosomal lipase. All of these different lipases have different functions in our body. But the one that we're specifically referring to in FCS is the one, it's called lipoprotein lipase, that's expressed specifically it's expressed in a few tissues, but the function that's most impacted is the one where it's expressed in our blood vessels, that's responsible for clearing it. Because what happens, as we know, with FCS is that you have a genetic mutation that's supposed to make this protein, this enzyme that's responsible for doing this function. But if you have a genetic mutation that basically leads to this enzyme to be missing or being defective such that it doesn't work properly, it might be there, it just might not function properly because of a defect in its structure, or in some cases people have mutations where the complete enzyme is not even expressed because it's completely defective essentially. So when this particular enzyme is missing or not doing its job, you get accumulation of these chylomicrons, these fat globules that are circulating in your blood, and they will continue to circulate. In an average normal person, chylomicrons are supposed to be cleared up right away. But if your lipoprotein lipase is not working, it's not going to be cleared up. It will stay in the bloodstream. And then what happens when it basically stays in our bloodstream is that we get something called hypertriglyceridemia or hyperchylomicronemia. That happens because it's, as I said, it's staying. But when it's staying in our blood and it's not being cleared, it can go to all sorts of different places and cause inflammation. And the organ in which it's most targeted to cause inflammation, it's the pancreas, because pancreas is involved heavily in digestion. It's also the place where chylomicrons can accumulate. And when that inflammation does happen, you get attacks like acute pancreatitis. And that's one of the defining features of FCS is having recurrent pancreatitis. We will talk a little bit more about pancreas itself later, but I just wanted to get the basics out first, essentially. So medically speaking, FCS is a rare recessive genetic disorder that's defined by having uncontrolled high levels of hypertriglyceridemia and recurrent pancreatitis. It's also very important to note that hypertriglyceridemia is actually quite common in the general population. Lots of people have high triglycerides, although the level to which we see the increase in FCS is substantially higher. Because FCS is not the only reason that somebody might have hypertriglycerides. People can have high triglycerides due to other secondary factors, like alcohol, like obesity or pregnancy, or even other multifactorial or polygenic causes where there's multiple genes that are involved in leading to high triglycerides. But when we talk about FCS, we're specifically talking about a mutation that's occurred in either the LPL gene or its regulatory genes. So basically our body has cells, our cells have DNA, and our DNA have chromosomes, and essentially those chromosomes carry different genes. So the lipoprotein lipase gene specifically is actually on chromosome 8. We get each copy of our gene. For each one, we have 2 copies, and each copy comes from each one of our parents. It's called an autosomal recessive disorder because you have both of those mutated copies that would result in a homozygous loss of function. So when people say homozygous or biallelic loss of function or autosomal recessive, it's all referring to the same genetic pattern of inheritance of FCS. They all basically mean the same thing. So FCS itself can be caused by that mutation occurring either in the LPL gene, or which is primarily most of the population, greater than 90% have that mutation, or it can happen in the regulators genes, which are ApoC2, ApoA5, LMF1, and the GP1HBP1 genes. You can have mutations in any one of those genes as well, and you would still have FCS if you had both of those defective copies. So what these mutations essentially do in our body is that it leads to inability to break down fats that you're ingesting and causing triglycerides to build up in the blood. And it can cause sometimes serious illness because this excess can lead to complications with, again, in blood or organs, or cause other inflammation in the body. Overall, in research, the FCS prevalence is 1 in 100,000 to 1 in a million. There are some research papers that quote 1 in a million or 2 million. We don't actually know the exact prevalence, and that's because it's quite rare. So it's kind of hard to determine how many people truly actually have it. So I'm just going to dig in just a little bit more to clarify, again, the genetic inheritance pattern. So as we discussed, basically in FCS, you have both copies of the gene in each cell that have the pathogenic mutation, that has the mutation. So when you have parents, if you have the disease, you would have had both of the parents have at least one copy of it. And those people are called heterozygotes. So when people have one copy and they're carriers, those are heterozygotes for that mutation. And in research, we speculate that if family members are affected by only one copy in either the LPL or the other regulator genes, they may have anywhere from normal to mild or severe hypertriglyceridemia. it's kind of unpredictable. There's not really a correlation between a clear correlation between the genotype and the phenotype, meaning what we see in genes correlated to what's actually being exhibited in the person by looking at their blood work. But what can happen is that even if you're a carrier, there is potential that that might put you at increased risk of health problems such as heart disease or diabetes. Just something to caution. Those also are very common in the general population and can happen due to a lot of different reasons, apart from genetics. Smoking, lifestyle factors, physical activity, exposure to certain risk factors. And so it's not very clear if carrier individuals are truly more prone to develop these health problems than individuals in the general population. So now we're going to talk about, switch gears a little bit on understanding lipids when they show up in our blood work. So I will just start by explaining a little bit about cholesterol and triglycerides. So those are both, because they're fats, they're insoluble in water. And our blood is mostly water-based. So these fats, triglycerides and cholesterol, basically have to be carried around by special compounds that are made of fat and protein. And that's what a lipoprotein is. A lipoprotein is essentially a car. I would basically say it's analogous to a car, which has passengers like cholesterol, triglycerides, phospholipids, and other fats in them. There are 4 major types of lipoproteins, classes that we look at that circulate in our blood. And those are chylomicrons, which are most relevant to FCS, that contain triglycerides. We have very low density lipoproteins, VLDL. We have low density lipoproteins, LDL, and high density lipoproteins, which are HDL. And we know a little bit, and we do have an understanding of how some of these might be related to disease and how it impacts the human body. So when you look at a lipid panel, when you look at blood work that we do on people, there's something called total cholesterol. So total cholesterol is actually it's a sum of both LDL-C and HDL-C. And you might have come across this quite commonly, the saying is LDL and VLDL are considered bad cholesterol because they are significantly correlated with cardiovascular and atherosclerotic disease. I do have some anecdotal evidence and from conversations with some of my mentors who are endocrinologists who work with FCS patients that LDL and VLDL tend to actually be lower in FCS patients. I'm not quite sure why yet, but we'll keep looking into that. And HDL is the good cholesterol because it's protective against cardiovascular disease or other heart disease. Triglycerides, which is what the main focus is of FCS and what we look mostly at, are when they're higher than a certain threshold, generally 4.5 millimole per liter. That's usually, those are the units that we use in Canada. I think that's similar in Europe as well. The units are different in America. I might talk a little bit about that later as well. But it's important to note that LDL-C is actually a calculation. And that calculation is not done if your threshold, if you have your triglycerides higher than a certain level. So in a lot of FCS patients, we can't actually see the LDL-C because the formula basically that's used as the Friedwald equation for calculating LDL-C doesn't work properly if you have higher triglycerides. That's why it might say on your blood reports that it wasn't calculated. or in some cases, if at any given time your lipids are a bit too high, even some of the other things might be too lipemic, they might be too fatty for them to calculate some of these, and that includes things like HDLC or non-HDLC, or liver function tests like ALT and AST might not also be seen sometimes in when you're having high lipids. So the AST and ALT are liver function tests that are also done on patients, just to see how if it's having any impact on your liver, because some patients with FCS do develop in later life diseases like fatty liver disease, or have effect on their hepatic functioning. And then the last one on here is ApoB, which is found in LDL. We also can look at this in blood work to assess cardiovascular risk, because it's also very closely tied to having a high concentration of ApoB with having a risk of cardiovascular disease. So signs and symptoms, I will just go over this, maybe not too much in detail, because most of you might be very familiar with it, but we will speak about, so one of the things that happens in FCS, as you know, is that when you collect blood, it might look milky white or yellowish in appearance, and that happens because of the chylomicrons in the blood. And that's actually how my husband was diagnosed, when they collected his blood when he had his accident, and they realized that did not look normal. And one of the other visible signs are things like eruptive xanthomas, and that those can basically show up. It varies in people. They can be, they might be on the trunk, they might be on the face, they might be on knees or arms. It can, and depending on how high your levels are at any given time, they tend to be pretty small in diameter, about like 1 millimeter, and tend not to be painful unless there's like a lot of friction or repeated abrasion to the area. And when the fat levels basically drop, they tend to disappear. FCS is not the only condition in which you see eruptive xanthomas. You can have it just due to hypertriglyceridemia in other conditions as well. In uncontrolled diabetes, for example, like those have it too. But the level it might happen, again, in FCS tends to be varies by patient. In my experience with my husband, his doesn't show up until he has higher than 30 millimole per liter of triglycerides in his blood, but it might be different for different patients. So I can kind of see when that's happening, that he's pretty close to having a pancreatitis episode, and we can sort of slow down or change, take the stress away from his body by maybe reducing solid food intake and switching to maybe a liquid diet. But again, this varies, and you have to do basically what works for you. Another clinical the sign that we look at is something called lipemia retinalis. So our fats can also build up in the back of our eye, in the retina. And that has the retinal vein can have a pale pink appearance when on examination, when you look into the eye. And that also happens at a certain threshold of having triglycerides. And the usual symptoms like the fatigue, memory loss, fogginess, headaches are also tied to FCS. And in some people, this might happen only when it's very, very high, or it might be in the background always, which is abdominal pain, vomiting, indigestion, fatty stools. That might also be present. So on the table here, this shows basically the prevalence of all of those symptoms, and one of the most common ones, and obviously the identifying features, is acute recurrent pancreatitis. So how we diagnose FCS is primarily, first indication would be a clinical diagnosis based off of the signs and symptoms that I just mentioned. The laboratory findings on blood tests, the abnormally high triglycerides, or more specifically, the threshold that's what we've come up with is 10 fasting plasma triglyceride concentration of 10 millimole per liter. And in American units, like it would be 885 milligram per deciliter. Although in experience, majority of FCS patients are actually usually higher than 15 to 20 millimole per liter in blood without having pancreatitis necessarily. And the classical diagnosis that used to be done before was looking at an assay and looking at LPL activity that was obtained. And basically, we would look at it and say that if there's a marked reduction in or absence of lipoprotein lipase activity, you could document that the patient likely has LPL deficiency. However, this assay is not used anymore in clinical setting, because of its reliability, because the results vary depending on the lab that does this. It's not the most, I would say, diagnostic way of diagnosing the disease. What we look at now is the next generation sequencing of the 5 FCS causing genes that we discussed earlier. That's the gold standard for diagnosis. We can do molecular genetic testing in a single gene or a multi-gene panel to find the mutations in LPL and do the diagnosis through genetic testing. So in summary, the 2 main diagnostic features are a blood test showing high hypertriglyceridemia combined with symptoms of nausea, vomiting, or in childhood, sometimes it can be failure to thrive or abdominal pain in infancy or childhood repeated episodes of acute pancreatitis requiring hospitalization. My husband himself has been hospitalized over at least 40 times with acute pancreatitis in his life. And it used to happen more so in his childhood than it does now. Genetic testing, again, is the other feature. And I think that's an important one because people who have FCS, unfortunately, sometimes are not diagnosed until adulthood or later in childhood or receive inappropriate treatment because of unfamiliarity with the disorder. Because people might not know about it, and again, it's also because there just isn't enough conversation, and again, my husband, as children, when they get sick, they would be given treats like chocolates and ice cream to make him feel better, and that would obviously make him feel sicker because the parents didn't really know exactly what was going on, even though he had a whole bunch of testing. A lipid panel was not something that came to their mind because they didn't think that was relevant to check for. And this is also an important note. Again, I wanted to clarify that if you have FCS that's caused by the lipoprotein lipase gene or the other non-LPL genes, the phenotype or like what we see in the patient might look very similar. We can't necessarily tell which genetic mutation a person has just by looking at their clinical presentation. However, LPL deficient patients generally tend to have lower LPL activity in assays, and they trend toward higher triglycerides than people who have other mutations in their regulatory genes. So complications, as we know, are sometimes a part of having severe hypertriglyceridemia, and one of them is acute pancreatitis. I briefly talked about this earlier, but again, I want to take a moment to talk a little bit about pancreas. So pancreas is a very important organ in our body, and it's responsible for producing hormones like insulin and glucagon that are responsible for taking care of glucose and so basically sugars in our body, either the breakdown of it or removing them from our bloodstream. And that's called the endocrine function of a pancreas. And then you have an exocrine function of pancreas, which is to produce digestive enzymes. And those are things like amylase, protease, and lipase. This is a pancreatic lipase. This is a different lipase than the one that we've been talking about this whole time. So these enzymes are responsible for breaking down foods. So what happens is that when you have inflammation and in an acute pancreatitis, you there's not much we can do other than to provide supportive care, which is, stopping oral intake, and that's to let your body essentially rest from this accumulation. And we can provide hydration and IV fluids, and also pain management, because it can be quite painful for patients. And what we can do is monitor for development of complications, such as pancreatic necrosis or pancreatic abscesses. And in severe cases, it can happen organ failure. I do know of patients who have gone through that as well, from an episode of acute pancreatitis to having eventually a clot and therefore severe organ failure. Although that does happen, not commonly, but there are some basically precipitating factors that can lead to that. And I'll be talking about what those precipitating factors sometimes might be. And again, you have to be an advocate for your own self as a patient. If you know that this is something that you've been having, it's important to let the doctor know if you're going to the emergency, that this is what you think you might be having, because that can save sometimes a lot of time and get you the appropriate treatment you need. And it might not be necessary to do a CT scan every single time to see what's going on. It might still be necessary in some cases, because there might be more going on than just an acute, other than acute pancreatitis. But it is important to let the person know, because not every doctor that you're going to come across is going to know what the condition necessarily is, or what might it present as. Another thing, unfortunately, that can happen in ER, again, it's happened to some of the patients that I know, is because acute pancreatitis can also happen due to alcohol excess. It's called alcoholic pancreatitis. It can prevent people from receiving the correct pain management treatment, because it might be looked as opioid seeking behavior. Because, as you know, one of the ways to manage pain in pancreatitis is opioids. So it's very important to clarify and that this is not drug seeking behavior. This is important, because this is how you're feeling. And in ER, sometimes my husband has been delayed for hours to receive pain medication until he has been assessed. So it's just to be mindful of, and to know what's happening, and to let them know. And also some of the other things that can happen are chronic pancreatitis over time, pancreatic insufficiency. So you'll see that there are patients who receive things like Creon, which are basically enzymes like amylase, protease, and lipase that are given to patients. And that happens because when your own pancreas is not producing those enzymes, that's the indication in which you would give those medications. It can lead to diabetes. A lot of FCS patients have diabetes as well, because of the pancreatic insufficiency in producing insulin. And things like pancreatic pseudocysts. And this one is a little bit controversial and not sort of clear. And it's the link to atherosclerotic disease. Our understanding sometimes is that chylomicrons are too big to cause atherosclerotic disease, although there is some research that might not necessarily be true, that FCS might also be linked to some, or might play a role in other sort of disease, or put you at a risk for, say, cardiovascular disease, but that link is not clear. And we don't quite know the pathophysiological mechanism by which that may or may not happen. I wanted to also briefly talk about pregnancy and FCS, because this is a topic that I find is not necessarily discussed with women in FCS. My sister-in-law, for example, when she got pregnant, didn't quite receive any of this information or guidance prior to becoming pregnant, and she had a lot of complications and ending up in the ER essentially every 2 to 3 weeks. So it's very important. There's two components to this. One is genetic counseling. We have discussed the inheritance pattern. So it's important to understand that if each parent is a carrier, there's a 25% chance that your child will have FCS. and a 50% chance that, that they will receive one of the mutated copies of the gene. And there's still a 25% chance that they might be completely unaffected and not a carrier at all if two parents are carrier. But if you have FCS, meaning you have two mutated copies, there's 100% chance that your offspring will be a carrier. They will receive one of the copies. And if your partner is not a carrier, there's a 0% chance that your child will have FCS if your partner is not a carrier for FCS. So you can do carrier testing for at-risk relatives. You can do prenatal testing for pregnancies at increased risk if you know the pathogenic variants in the family. Again, pregnancy of note. Pregnancy in itself can raise triglycerides, just normal pregnancy. In second and third trimester, a lot of women develop gestational diabetes. They have insulin resistance. Hormones like estrogen, progesterone, placental lactogen all increase triglycerides. So it's very important, more so in women with FCS, that there's appropriate pregnancy management. In some literature, it's recommended that there's extreme dietary fat restriction to less than 2 grams a day, which I can imagine is very, very difficult, because even right now with our current trying our best, we are only able to do like 10 to 20 grams for Zubair, and very close monitoring in the third trimester for triglyceride concentration to prevent further complications for the child and the mother. There's also indication of plasmapheresis being used to remove triglycerides in the blood in pregnant women with very severe hypertriglyceridemia, not so much as a usual management option for FCS. I wanted to discuss and highlight some of these medications, just as a caution that these are something that you might want to discuss closely with your doctor to assess the benefit and risk. So highlighting these does not necessarily mean that you cannot take these medications or you should not. Pointing this just means that these are associated with higher levels of triglyceride concentrations, and you have to assess whether the benefit of taking that medication is more than the risk you might face from taking it. And because that's how we give any medication in real life as well, that the benefit is more than the risks that are associated with it. But also to highlight that if you are on these medications, there might be even more an indication to do close monitoring to see how it might be impacting your body. Because a lot of women are not given counseling about specifically things like oral contraceptives and how it might affect women with FCS, because they have estrogen, they have their estrogen receptor agonists. And then there are other things that I've highlighted here too that we found in research to have correlation to it. Things like protease inhibitors that's used in HIV treatment, I believe. There's diuretics that are sometimes given as an antihypertensive or in blood pressure. There's retinoids that are used for usually skin conditions, corticosteroids, some basically antipsychotics and antidepressant drugs, or selective serotonin reuptake inhibitors that are given for anxiety may also raise triglycerides. There are some antihypertensives, such as beta adrenergic blocking agents, as well as I mentioned, diuretics might be worth talking about. And propofol is usually given as an anesthetic when you're having sometimes in a procedure, not always. And L-asparaginase is it's a medication that's used in acute lymphocytic leukemia. There's immunosuppressives, not all immunosuppressives, some of them. And this one is an important one. This is another controversial one that's usually talked about, is fish oil supplements and omega-3s. So from what I have found, it's and from conversations again with actual endocrinologists working with FCS, we don't think it's a good idea necessarily to use over-the-counter omega-3 or fish oil supplements, because they can contribute to chylomicron levels. But that does not mean that prescription fish oil supplements or omega-3s like Vasepa, for example, might be useful in some patients. They do have some clinical utility, but I would definitely caution you to against over-the-counter ones. Because they're not tightly controlled or regulated. We don't exactly know necessarily the composition of the fat levels in those supplements. And more again, so especially you should be concerned if you have conditions like diabetes, obesity, or alcohol use, to caution against. So management as it stands right now, just quickly going over the lifestyle and diet. So the recommendation is that the dietary fat should be restricted to less than 5 to 10% of calories, total calories consumed. So that's generally recommended at less than 20 grams. I know a lot of the patients try and do less than 10 grams. So to the best of your ability, but I know this is a very difficult diet to maintain, because I see it every day. I hide chips and nuts from my husband in my house. So I know this is, and this is not even just about chips and nuts. It's even the most simplest things like breakfast, like yolk in an egg can have a lot of fat. And that's, if that's the fat you've consumed, then that might be it for you for the day. And it's really hard to imagine. Almost everything has fat, except things like vegetables and herbs. So a plant-based diet might be a very good recommendation. There's another resources at the end of this presentation, a very good lecture that was given earlier by Dr. Paolo Perini and a nutritionist. And I have a link to that. It's a YouTube video, but there's another really good resource. There's another research paper published on diet recommendations in FCS. That's another resource that I've attached, and it sort of gives you like a sample diet diary or things to consider and foods to consider. That might be helpful to some of you. And also another recommendation is losing weight if you are overweight, or bariatric surgery if you're obese and have a BMI over a certain threshold. It's recommended that there's no alcohol use, or at least at the minimum alcohol reduction, and MCT oil supplementation, because MCT oil is not processed to the same pathway. MCT oil does not tend to contribute to chylomicron levels in the blood. And there is also, if this is needed, a fat-soluble vitamin supplementation. So these are your ADEK vitamins that might be helpful. The current drugs on the market that have been used for a few decades and that already exist in treating hypertriglyceridemia, some of them, actually most of them that already exist, have very limited benefit in patients with FCS. But there are some that still might have a limited response in people with FCS. So we'll start with fibrates. So commonly prescribed medications are things like fenofibrates and gemfibrozil. There is generally limited response because they rely on activity of lipoprotein lipase, because lipoprotein lipase is basically an enzyme that can be activated or deactivated by certain proteins and certain things. But if you don't have a functional LPL, a fibrate might not work necessarily. And niacin is also shown to be minimally effective, but limited tolerance and due to side effects that people have. But there may be some clinical utility of the medication. Omega-3 fatty acids, I spoke briefly about this. There is potential effectiveness in some small and controlled trials, but it does not seem to be efficacious in long-term or controlled trials of FCS. And the results that I've found so far tend to be inconsistent. Although, again, there is some anecdotal evidence that, that it might work in some patients. So, some of these may still be helpful for you if you do not have complete loss of function mutations in the lipolytic pathway. Or there are other components or components of secondary hypertriglyceridemia, meaning that in addition to FCS, there are other factors that are raising triglycerides. So some of these might still address it. So even though you might not see a substantial decrease in your triglyceride, for some patients, you might still see a decrease. So you just have to see and I guess do trial and error with your doctor and see what is working for you. If it works for you, that's great. If it's not working for you, then you have to discuss whether there is any utility in you continue to take a drug that might not be necessarily doing anything. So these are, I've compiled a list of therapeutics that I've come across. And the purpose of this slide is sort of just to update people, because you might have come across some of these yourself and maybe wondering if these are some of the ones that can be used in treatment for your disease or for your loved one or for your patient. So the first one is CAT-2003. It was a novel conjugate of EPA and niacin. It was given to 13 FCS patients in a pilot study. I did not find any results of that study, so we're not really sure what happened with it. And this was a bit ago, so I'm not sure if the results were positive or not, but it doesn't seem like it's in development any further. Orlistat, it's a pancreatic lipase inhibitor. So what this does is it basically reduces fat absorption in our body. So the idea is that if we can reduce your body's ability to take fat anyway when you ingest food, then you would have lower triglycerides. So this is actually it's used as a weight loss medication. It's over the counter actually in North America. I'm not sure. I think there's someone who's not. Sorry, just give me 1 second here. Okay. So Orlistat, again, sorry, I was just saying it's used, it's given over the counter. It has been shown to be effective. Sorry, there was a small study with 2 children with FCS. There was a more recent study with an adult female with FCS, and there was actually one older study with a male who was given this drug and seemed to have reduction in triglyceride. The reason I didn't include that one is because I wasn't quite sure, the research paper didn't quite clearly show that this patient had genetically diagnosed FCS. So he might have had severe hypertriglyceridemia due to other genetic causes. But I do think this drug shows promise. And in my conversation with an endocrinologist, and actually this is a doctor on medical advisory committee of FCS, he does use orlistat in his patients. With some benefit. And then the next one is lamidopide. So this particular one was effective in preventing pancreatitis in a patient with FCS. This was a single case study, but it resulted in liver fibrosis over time. But this is a drug that's used in familial hypercholesteremia, which is a different disorder. So very limited evidence with potential serious side effect. And this one right here, predigestat, is also present in some of the couple studies, and it's shown to substantially reduce triglyceride levels in FCS patients, but there were very frequent side effects of this medication that halted development. So it's not available to be used for this indication. Last one, I briefly spoke about plasmapheresis. So I know that some patients may get this as a regular treatment, although it's not usual. It may have a role in patients with extreme hypertriglyceridemia and recurrent pancreatitis, maybe I would say in a hospital or in pregnant women with FCS, but otherwise as a recommendation, as a general treatment, it's not recommended because there's not enough evidence to say that this is helpful. And then this is just a summary of some of the medications that are more novel treatments that are out there. So I will start by talking about, first of all, with with gene therapy. So gene therapy is basically targeted at basically fixing the genetic problem. There was a drug called Glibera. Some of you might have been in trial for it back in, I believe, 2015, but it's no longer available. I do know it was approved in the European Union, but the company did not seek license in North America, even though it was actually invented by a Canadian scientist. But because of that, because of the fact that this was a drug that showed potential long-term benefit, the National Research Council of Canada committed to reinventing it. And there is an update as of 2022. There is a gene therapy developer who did receive funding from the National Research Council to come up with a more cost-effective and scalable gene therapy for FCS. So there is some hope there, essentially, that this may be something to look forward to over the next few years. The next one are ANGPLT3 inhibitors. So you might have heard of a drug called Evinacumab. I'm not sure if that's exactly how it's pronounced, but this drug did show some quite good effectiveness in patients with moderate hypertriglyceridemia, but it did not seem to work necessarily in patients with FCS. It did not show a significant reduction in triglycerides in FCS patients. And then there was Ionis ANGPLT3, which was a drug called buprenorphine, and it was discontinued after phase 2 because of side effects and increase in liver fat and enzymes. The one that I'm personally most looking forward to is ApoC3 inhibitor. So as I discussed earlier, so lipoprotein lipase can be activated or deactivated by certain proteins. ApoC3 is basically an inhibitor of lipoprotein lipase. And what the drugs are targeting is basically stopping the action of ApoC3 on various things. So ApoC3 has more action than just working on lipoprotein lipase. So it's basically predicted that we think that there's another pathway through which ApoC3 helps in reducing triglycerides. And so one of the more famous ApoC3 inhibitors that most people here may know about is volanesorsen. So Valeria showed that mean triglyceride levels decreased by 77% in the treated patient. And this was launched in European Union. And so far, according to my research, it's actually available now in England as well. It was not previously, but it is now. It's not approved by the FDA in North America due to concerns surrounding thrombocytopenia, meaning low platelets. Some physicians and researchers argue that because there's no other treatment, it would have made sense to still approve this, but it's not, because you can monitor low platelets. But that is one of the concerns with volanesorsen, is in some patients they do experience this drop in low platelets, which puts you at an increased risk of bleeding, essentially. The next one of the same ApoC3 inhibitors is the Ionis Exia ApoC3, and that's an active clinical trial right now, and it is recruiting patients in phase 3 of clinical trial. So that trial right now has sites in US, Canada, France, and Spain. And there is a link to it again in the resources that I will also copy to this chat. The last one is Arrowhead ApoC3. It's also an active clinical trial recruiting FCS patients in phase 3. Again, this drug is showing promise, and some say it's a better version of volanesorsen. So we'll see. It's still in phase 3, actively recruiting in United States, Canada, and Mexico. When you click on these links, you'll be able to see exactly which sites, which regions in those particular countries has the clinical trial that's active. In Europe, there is active recruiting in Austria, Germany, and Poland. And as well as in Australia and New Zealand, there is a site. that's doing a clinical trial with Arrowhead ApoC3. So this is my list of resources I just wanted to show, and I will go ahead and actually I will copy them into the chat for people so they can make note of it right here. Let me just bring it here. Okay, so I've just copied the resources here. So I just did want to leave a little bit of time to have answer any questions or have a discussion if anyone had any. Again, thank you so much for your time and for coming today and listening to what I had to present. So if you have any questions, you can unmute yourself or put it in the chat. I will go ahead and wait for a few minutes here.
Fiza, thank you for this. That's been really helpful, and I have really enjoyed kind of having everything explained to me. Actually, one of the questions that always concerns me is long-term brain developments with the lack of fats, because I know that you know, fats, omega-3s and omega-6s are very important in brain development, and I don't feel that I probably get those from my diets. I just wondered whether the fish oils might actually compensate that for a bit, if you are aware of that, or if you have any anything to shed light on.
Yeah, so with yeah, thank you so much for asking that question. That's something that I've also wondered myself. But because FCS is a very rare condition, there actually isn't a lot of research around even Vascepa itself in FCS. So we don't actually know you know, what kind of benefit it has, but you know, looking at generally what things like Vascepa and fish oil supplements do, you can imagine that that would help supplement. But I think where it's most required is in children, in young children, and in childhood, when brain development is happening rapidly. And I would actually invite, if somebody wants to speak, I believe we had a neurologist here in our audience who might be able to speak a little bit more to that if they have experience on it. But what I have found in research is that in young children, the MCT supplementation, the MCT oil, is supposed to basically take care of that. To what degree it does that, I'm not sure, because there's not really much evidence there to find out. But it seems though that the brain development tends to still happen you know, normally. Like a lot of the patients that I have met with FCS and in my own you know, personal life, it doesn't seem to have impacted brain development from my understanding. But I can imagine that it does have potential to impact it in ways, but maybe the MCT supplementation is perhaps enough to replace that. So again, I'm not sure who it was, and if you would like to speak, you can speak a little bit more to that.
Hi, I'm Naeem Bray from Cape Town, all the way down south. I'm the neurologist with two young kids. Thank you for an excellent talk, and thank you for arranging this meeting. It's been enlightening. It's one of the first forums I've sort of met other individuals and family members with FCS. So I must, a big disclaimer, I'm an adult neurologist. I don't specifically, I've not trained in dealing with children, but I can just speak from personal experience in that my kids, they do appear slightly, they definitely become more irritable once their lipids rise. And I'm not sure if it's the specific mutation that seems to be very aggressive, but they had very high triglycerides in the order of, in excess of 700 millimoles, not milligrams. So yes, 700. So even though I've been a doctor for many years, when I walked into the ICU, I was in a different town. but I walked into the ICU and I saw 3 syringes, and it looked like, oh, this is the milk that they're feeding my son with. And then they said, no, look closer. And I picked it up and I looked around, and then I looked at the bottom, and then I saw a clot, and then I realized, oh, that's blood. So it was all essentially cream colored. So it was over 700. So my kids tend to run a lot higher, and I noticed they are irritable and short-tempered. But the rest of the development, at times I do have some concerns, but at other times they seem to be really well functioning. So I think overall development is good. I don't think MCT can supplement all the fats that are required for neuronal development, for example. And there is an area that I'm slightly concerned, because the dietitians over the last few years have given me conflicting advice with regards to omega-3 specifically. And some have advised that fish oils are great, and 2 of them said fish oils are great, and then the third one said no, fish oils are a bad idea. And so currently we are using walnut oil, which is meant to have a good ratio of, I think, ALA and I've forgotten the names of the fatty acids, and that should be sufficient for neuronal development. So in summary, I think by and large, the encephalopathy, the lipid encephalopathy that they speak about is really when the triglycerides are very high, but development, if you're supplementing reasonably well, should be fine.
Okay, brilliant. So we our dietitians also with children recommend walnut oil, actually.
Okay.
But I would, I don't know, I'm not a medical person, so I would say go to your dietitian and talk to them.
For sure.
Yeah. And I would also like to share that as a child, I was very irritable with high triglycerides. So I think that is very much, I recognize that completely.
Sure.
Yeah. We do have another question here, which is from Juan. And we've been wondering what you mean by liquid diets. We have a 1.5-year-old baby boy with FCS. He was diagnosed 2 weeks after birth. So I don't know if you could tell us more about the liquid diet you were mentioning.
Yeah, so essentially, I will caution though that the liquid diet is not necessarily some scientific method that's there. However, because when we treat acute pancreatitis, what we do is we supplement, we stop oral intake. The reason to stop oral intake again is to give your body a rest, and it's sort of a similar idea. So when I can see that higher levels might be basically heading towards an acute pancreatitis episode, it's more like fasting. It's like with fasting, with maybe just having a little bit of juices or just water, essentially, to give your body a break from and essentially letting it process all this buildup of chylomicrons in the blood. Now, with a 1.5-year-old, that can be very difficult and might not be even safe to do. So that is something you would have to, again, discuss with your endocrinologist, because obviously it is with an adult. We can kind of see, what the needs are, and adults in general tend to be okay fasting for 24 to 48 hours. Nothing quite happens. But in a child, it's very, very different. And I would actually very caution against trying something like that with a baby that small.
Yeah, thank you. We were just wondering out of curiosity, so looking forward to him growing up and learning to live by himself with the condition, right? So that's why, out of just curiosity, he basically eats a lot of vegetables, and we monitor that very closely. We are very lucky enough to have an expert here in Hamburg, in Germany, that is specialized also in this thing. So therefore, we were just curious about what exactly.
Oh, for sure. No, I think that's quite fair. And also because, and in my experience, it seems to help, because before my husband met me, he used to have quite a few episodes of pancreatitis over and over again. And in the 5 years that we've been together, he's had only 2. And and basically when I can see, and he didn't actually even realize what eruptive xanthomas was, and he used to call them pimples, and explained to him that those were not pimples. We can see that there's a buildup of the fat, and then restricting his diet gives him that break and basically prevents him from being in extreme pain and ending up in the hospital. So it seems to work. And again, it's just basically what it is. It's just a break because your body needs to clear that buildup, and that's exactly what they do in the hospital too. The only difference is, in a hospital, if you are at that level, they would supplement with IV fluids like normal saline or even dextrose, for example, to supplement what you might need for, I guess, nutrition per se. But you can still do that a little bit with like mild fasting, I would say, in adults.
Thank you. Chris, you have your hand up.
Yes, thank you so much for your talk. It was really amazing. I'm a patient with FCS and a family doctor in the UK. I noticed on one of your slides that it said in the symptoms about numbness, and I just wondered what, and maybe other patients that are listening, what they're experiencing with that, and what the kind of how that relates to triglycerides. Is that something that is, if the triglycerides are very high, is that more common? I've actually had numbness, for many years, and had nerve conduction studies and things like that are all normal. So actually I'd never really put that link together. I was just wondering what people's views were.
Yeah, thanks for asking that question and for speaking. Yeah, so I personally had not come across numbness myself before. This is actually this was in a compilation of, I guess, a literature review. I believe this is from, a more recent, sorry, I can actually just trying to see where this figure is from. Yeah, it's in clinical findings and therapeutics options in chylomicronemia syndrome. So it seems as though they have found this in research that numbness might be one of the clinical signs and symptoms of severe hypertriglyceridemia, not even necessarily just FCS. So where that exact link or pathophysiology is, we would have to dig more. I'm not personally sure. We can look into it, but it is something that they have found that patients can have when you have very high triglycerides. So yours may be linked to that or something else. We're not sure, but it can be for sure.
Okay. I noticed on the same slide actually that there was asthenia, and I didn't know what that was, but I did look it up, and it's fatigue and tiredness, isn't it? So we hear that a lot within the patient group, that people feel very low in energy and very, very tired.
Yeah, almost 33% of
Yeah.
patients reported that as being one of the things that they experience, and going through even like crashes of like within the day of having energy and then not having energy, similar to sometimes that can happen with patients with diabetes. So it's common. I have seen it in my husband as well. It happens. So it's common, I guess, with and not even just that, things like memory loss and fogginess, like not like long-term memory loss. It seems like it's more like having like a brain fog. There's a lot of conditions that can do that as well, though. So you have to be careful to linking everything to FCS. It may or may not be, because it's a non-specific symptom.
Okay, that's a useful point to make actually, because just because you have FCS doesn't mean that everything happens to you is because of that, which can sometimes as a patient be quite easy to try and kind of pin it on and not think about other things you can do, which might relieve a symptom because you're just thinking it's to do with the one thing. So yeah,
I do have a direct question here. I'm just going to assess if this is something we can actually talk about in this talk, because we'll just have to look at it. Just give me 1 second here while I take a moment to read this question. Yeah, sorry. So John, thank you for sending the question. I can see that it's a very specific question, and actually, Jill, actually, it might be worthwhile to maybe stop recording, because some of it might be personal information that we
Okay,
would.
all right, I shall do that. So I'll just put on record, thank you so much for doing the presentation, Fiza. I think everybody has got a great deal of benefit from it, and hopefully many more will do when we share it amongst the community. So thank you.
No, thank you again for having me. I'm so glad this has been quite enlightening for myself as well. And this is the first time I've actually, in a forum like this, met other FCS patients. So it's really nice to have everyone join us.
Good.
Yeah,
I'll stop recording. Okay.